little more laterally, you see a continuous line of bone. You have the facets of all these vertebrae interlocking together. So at this level, you will not have any ultrasound beam passing through. If you come a little more laterally, you have this transverse process, this transverse process. In between the two, you have a huge window, and this is where you will find your lumbar plexus. So let us say you do a paramedian longitudinal scan. What you're trying to look at is the interlaminar space. You will see the erector spinae and the multifidus muscles, which are the paraspinal muscles. You will see the laminae there. You will see the ligamentum flavum. And then beneath that is the epidural space. Then you have the posterior dura, the thecal sac, and this is the anterior complex formed by the anterior dura, the posterior longitudinal ligament, and the body of the vertebral body over here. So if you translate that here, you will see that this, and this, these three are the laminae. That is the ligamentum flavum. This white line that you see is the posterior dura, and just above that is the epidural space. That is the thecal sac, and that would be your anterior complex there. If you see these three laminae, they look like the heads of galloping horses. Now, if you go a little more laterally and put your ultrasound beam, means the transducer overlying these facet joints, you will see that these are the articular processes of the facet joints. So this is one continuous line of bone, and does not allow any ultrasound beam to pass through. And if you see these actually resemble camel humps. So ultrasound for the spine actually refers to a lot of animals and animal parts. When you pick up patterns, you say camel humps, you say heads of galloping horses, frog's eyes. You also have cat's whiskers and bat's wings and so on. If you go a little more laterally, this is the transverse process, this is the transverse process, and this is another transverse process. You've put your ultrasound here. This is paramedian longitudinal. What you see is one transverse process here, this is one more, this is one more, and these are the acoustic shadows which are beneath the transverse processes. And in between these acoustic shadows, you see the acoustic window. That is the psoas muscle there, and in that psoas muscle will lie your lumbar plexus. And if you come lower down, you will have the peritoneum there, and beneath that, the intraperitoneal structures. So Manoj Karmakar has likened these three acoustic shadows to a lumbar ultrasound trident. If you go back to the trident that Lord Shiva uses, or the trident, if you are alluding to Greek literature, of Poseidon. Now let us look at the transverse view. When you put your probe just over a spinous process, in this case it is the L4 spinous process. Now this is bone, and bone will not transmit ultrasound. So what you see here is a bony shadow. But you will be able to pick up structures on either side of the transverse process, and on this side here, that is the laminae. And if you go farther away, you will see the transverse process here. And this hollow is where you will have the spinal canal, and that will be your vertebral body. You just have to correlate that with this picture below. So this is when you insonate on top of a spinous process. If you change the site of insonation, and now you put your transducer in transverse view, in between two spinous processes, what happens is an acoustic window opens up. And here there is no shadow, and the window will actually show you a white line there, which is the posterior dura. In a thin individual or a youngish patient, you will also be able to see a line there, which is the ligamentum flavum. Between the two is the epidural space. On either side, here there are no laminae. Here what you have are the facets. That are the facets, and if you go even more laterally, these are the transverse processes. This will be the thecal sac, and this again is the anterior complex. So how do you determine the insertion point? You place this transducer exactly in the midline in the interspinous space. You put one mark on top in the center. You put one mark at the side of the transducer, at the center of the transducer, one more on the other side. You connect these two lines and that is exactly where you need to put in your needle. And how do you determine depth to the epidural space? You have something we'll be showing you tomorrow in the workshop. There is something called software calipers, with which you can just draw a line from the skin down to the ligamentum flavum, and the distance, which is the depth, will be displayed somewhere there. And it is at that distance you would expect your needle to actually puncture the ligamentum flavum and enter the epidural space. So that is how you can calculate depth to the epidural space. And you can also identify at what angle your needle needs to go in order to reach this particular epidural space. So to conclude, let me look at the requisites. Because the spine, the structures that you wish to see are at a greater depth, you will need to use a low frequency curved probe, which is 2 to 5 megahertz. You need generous acoustic coupling. In this case, because most often we are going to do a pre-procedural scan, you don't need to maintain any sterility here. You could just use some ultrasound gel or some KY jelly. And the setting of the machine should either be the general or the penetration mode. The depth depends again on the patient's habitus. And you should first scan in the longitudinal axis to ascertain the space. If you want to put in your needle in the L4, L5 space, as I showed you in the previous slides, you must identify that space. The next thing you need to do is you scan in short axis to define the midline and to identify the depth from the skin to the ligamentum flavum. And the last point is most important. Practice, 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 and more practice. Thank you very much.